Next important leukemia, CLL. Why will you remember? You have a diagnosis, but there is no need of treatment. But the diagnosis is not a simple diagnosis like a headache or a stomachache. It's a diagnosis called leukemia, but the doctor says, no problem, you can go home, you can go to America, you can go to London, you can remarry, anything you can do is what he will tell the patient. That is called as CLL. Elderly patient, for some other reason, what is it called? Master health checkup. Right? So, has gone, complete blood picture is done, and they gave a report. Who gave a report? Laboratory guy gave a report. Your WBC count is very high, and there are smudge cells in the peripheral smear, but they are all mature looking small lymphocytes. You have a leukemia, is what patient will be told by a laboratory guy. Then he comes running to you, doctor, what is this leukemia? I am otherwise happy, planning to go to America. Last month same thing happened. One of our patients, Miss Shanta, she is a very sweet looking 74-year-old Carnatic Sangeet exponent who is our patient since past 25 years. So she came with her highly dedicated, committed stem cell like husband. So they both are planning to go to America to visit their son. So they got a complete blood picture done as a master checkup, and it turned out to be this. So nothing, there is nothing done for them. She is absolutely all right. She is now in New York to spending with her son. So most benign out of all leukemias is CLL, is what need to be remembered. Most common type of leukemia, especially in the elderly people, will be the CLL. Then it is the mature lymphocytes which you typically come across, and since it affects B cells, some can have impairment of their humoral immunity, and if that CBP would have not been done on Shanta, she would have never discovered she has got a CLL. So tomorrow when you are a medicine professor, after 60, to get an ECG you will remember one patient who had heart attack. To get a CUE you will remember a patient who had a bladder cancer whom you diagnosed and treated. To get a CVP you will be afraid because you will be discovered for CLL. Life is miserable ultimately as a medical man. Now doctor, what are the signs and symptoms? Patient can have lymphadenopathy and splenomegaly at the time of the discovery of this problem. Neutropenia, hypogammaglobulinemia can develop in them, and they can have infections. At a later stage, patient can have fever, night sweats, weight loss, anything, but generally it is when a unsuspecting CBP was done routinely, patients will be discovered. And how will you evaluate? If there is a lymphadenopathy, you can do lymph node biopsy. Usually this is of a B cell origin. So what is the important CBP finding in CLL, doctor? When you prepare smear, you take one slide and create a smear, no? So while you are creating smear, that will injure that leukemic cell, and what you call is called as the broken lymphocyte, called smudge cell, which is considered to be, this is, see, you are able to see this, no? This is not like this cell. They both are leukemic cell, but this is under that slide. While slide is prepared, that got broken, smudge cell. So smudge cells are the important finding in case of the CLL. So this is an example of a mature looking CLL lymphocyte. B lymphocyte is what you are able to typically see. If you have a patient with lymphadenopathy, if you do the lymph node biopsy, what do you basically expect? all the lymph node architecture will suffer effacement. Predominantly lot of population of small lymphocytes is what you come across. Generally we don't do bone marrow biopsy. Why, doctor? First, we don't treat. We leave the granny without any further treatment with CLL. On the top of it, why to injure her with a biopsy of the bone marrow? So we do cytogenetics, which don't need a biopsy, and try to prognosticate the patient and ask them to go back to their home. But if you do biopsy in the early stage, you get what is called as a nodular pattern, and in the late stage what you get is called as a diffuse pattern in case of the chronic lymphocytic leukemia. So how will you treat, doctor? There is no cure. Since there is no cure, several treatments will be effective, right? If there is no chance of becoming happy, there are many ways of becoming miserable. So that is the thing. Watchful waiting is what you need to do, right? So what are the various drugs which are used in CLL? Fludarabine, which is a purine analog. So since lymphocytic cells are enthusiastically proliferating, they require a continuous supply of purines. A proliferating cell required to form DNA, no? So that supply will be blocked by giving a purine analog called fludarabine. Then CD20 is a very important receptor on those proliferating cells. So we use rituximab, which is the monoclonal antibody against CD20. Lot of times this is asked as an MCQ. Then alkylating agents, chlorambucil or cyclophosphamide we can use. It's called COP regime. Cyclophosphamide, vincristine. Vincristine means oncovin is the other petty name for it. Oncovin, hence called vincristine. Prednisolone, COP regime. Then if the patient is having hypogammaglobulinemia, then we give intravenously immunoglobulin G infusions. So these are the various things available in the management. This can be sometimes a bottleneck when it comes to MCQs in the exam. Now doctor, Roy staging for the CLL, you need to religiously remember what it is. If you find only lymphocytosis in a patient, you call CLL stage 0, no lymph nodes found. If the adenopathy is there, then you call 1. If splenomegaly is also there, you call stage 2. If the hemoglobin has gone below 10 means it is called stage 3, and the presence of thrombocytopenia makes it stage 4. In the Roy staging, one of the favorite tested high yield item in the exam. So what features suggest a poor prognosis in the case of the CLL, doctor? Basically obviously any advanced stage, age more than 70, but unfortunately it is found after 70 more commonly. Male sex, but our Shanta is a female patient, at least one good news. No response to therapy, we have not started therapy on Shanta. Lymphocyte count, it was 24,000 in her case, so more than 30,000 means Shanta is still lucky. Her hemoglobin was 14, I told Shanta to participate in next Olympics. So ultimately when you tell patient, they must really feel like participating in Olympics, right? So that's very important, doctor. Ultimately, never rob the hope from anybody just because you are a man of science and you know that patient belongs to poor prognostic group. So because if you rob the hope, patient fundamentally loses the taste for living, and anything that you tell to the patient they will remember, doctor, let me tell you. Until they come to your OPD, they will be thinking what doctor is going to tell me, and whatever you talk in the OPD, they keep talking about what you said for the next 1 year, probably their lifetime. There are patients about 10 years back who come and tell, that day doctor you made me laugh when I am having sepsis. Now I recovered from the ventilator, I am alright, I came back to you. then you won't remember the joke. That's a unfortunate thing. Then you will tell, do you remember the joke, doctor, which you told me on that sepsis? Oh, I am a regular professional joker. So that's the reason I don't know which joke I told, but you tell, I will recall, is what we have to end up in telling the patient. So that's very important, doctor. Then more than 10% pro-myelocytes, pro-lymphocytes if you discover, and similarly some chromosomal abnormalities which we will discuss now. So this is the basic yarn. Let's have some spicy clinical pearls. CLL, one peculiar cytogenetic thing is, it co-expresses CD19 and CD5. There is only one more malignancy, hematological malignancy, which co-expresses CD19-5. That's the reason it is important. That's called mantle cell lymphoma. We'll come back to that. So what is the hallmark of CLL? Only lymphocytes, isolated lymphocytosis is the hallmark. And what is the close differential diagnosis? Epstein-Barr virus infection also can lead to development of lymphocytosis. Whooping cough, pertussis can cause, but you don't find a 70-year-old woman suffering from whooping cough. But a lot of your patients found to have CLL or potential CLL, what you can tell, don't worry, we will check, maybe what it is we will evaluate. It can even be EBV. In fact, our patient Shanta brought a Google printout. My son in America, doctor, he is a top software engineer. He sent me this, that it can be Epstein-Barr virus infection. But doctor, there is something kissing disease written. Yeah, because Mr. Shanta is a very romantic, chasing, passionate husband. So you must tell some other story before the diagnosis comes to Shanta for her to go home and sleep the same way. So the WBC count is usually more than 20,000. Then what will CLL demonstrate, doctor? The CD19, which is the B lymphocyte marker, lineage marker, and CD5, which is the T lymphocyte marker. This is such a peculiar co-expressing feature which is unique, that only mantle cell lymphoma and CLL are the only ones who do this. Obviously the question comes, a frequently asked MCQ. How do you know whether it is mantle cell lymphoma or whether it is CLL? If you solve the previous AIMS question bank, medicine questions, some questions containing the CD markers will be there, and among the options will be given CLL or mantle cell lymphoma. So that's the reason it is important. CD23 expression is found. So CD19, CD5, both of them will express, but CD23 expression is a special feature of only CLL, not mantle cell lymphoma. Then the low expression of the surface immunoglobulin and CD20, their expression is low, is a feature of CLL but not mantle cell lymphoma. And cyclin D1, overexpression of this is a feature of mantle cell lymphoma but not CLL. So that is the important differentiator between these two. Then if at all a patient of CLL happen to express a mutated form of the immunoglobulin gene, surface immunoglobulin gene is there, no? Suppose if they happen to show the presence of it, then that's a good news, because such type of CLLs will show an indolent form of a disease which is smoldering, and patient will live very long. Then one more important thing is, those who are having indolent form, we said no, those who have a mutated form of immunoglobulin gene. One more way to say that they will show indolent course. Why will they show indolent? Means a very benign course, benign clinical course. Why? Because the surface antigen CD38 in them will be expressed very low, and there is one important protein called zeta associated protein which is not expressed by them. Expression of the zeta associated protein is bad, non-expression is good. Non-expression of the JAP, Zeta associated protein is a feature of the patients who have a mutated form of a immunoglobulin gene. Is all about the super duper gyan about CLL, which you need to remember if you can. So CD23 immunohistochemistry, CD5 immunohistochemistry, and CD23 expression makes that this is a CLL but not mantle cell lymphoma. But CD5 is expressed by both. CD5, CD19 are expressed by both CLL and also mantle cell lymphoma. That's what you have to ultimately remember. So what are the cytogenetics, doctor, and what is the prognosis is a very, very important issue. Chromosome 17p or 11q, poor prognosis. If somebody has only the deletion of 13q, if that is the only genomic change, very favorable outcome. Then what are the indications for treatment? Okay, most of the times we will say don't worry, go home, nothing will happen. But is there any need for treatment? Yes sir. If there is any progressive fatigue, fatigue means anemia, anemia means stage, quickly 2 or 3, rise staging you don't forget doc. If there is a symptomatic lymphadenopathy, lymphadenopathy stage 1, 0, it starts with 0, no? Oh, that's a whole problem. So who asked right to start from stage 0? Stage 1 say is better. So symptomatic lymphadenopathy or anemia or thrombocytopenia, or if they have a rise stage 2 or rise stage 3 or 4, and if they are symptomatic, then that becomes an indication for treatment. So what is the initial treatment of CLL if you happen to initiate, doctor? Fludarabine along with rituximab. To that you may or may not add cyclophosphamide. That is the typical regime in the case of the CLL. If you add cyclophosphamide, it will have a better anti-leukemic effect, but the problem is if you add cyclophosphamide, the myeloablative nature of it is so high that it leads to leukopenia, which lead to severe infection. But cyclophosphamide may or may not be added, but rituximab fludarabine is the starting point. Before fludarabine, the purine analog was discovered. The main part of the treatment used to be chlorambucil. Now we are in the modern era, we are shooting rocket to Mars, Mercury. Recently from ISRO, we are in the modern era of shooting rockets like monoclonal antibodies. So which one will remember for CLL, doctor? Alemtuzumab is what you need to remember if it is a refractory CLL. If you give that, it will go and nicely clean the blood and bone marrow out of all these malignant lymphocytes. But it leads to significant immunosuppression and lead to development of fatal infections. Then if there are any refractory cases, we use lenalidomide, thalidomide's big brother, refractory cases. There is one investigational agent called flavopridol. If you are too obsessive of getting top rank in MD entrance, you may still remember, right? Then if the examiner asks flavopridol, I don't think somebody, unless some luck factor is there, they will be able to answer. Now especially if the patient shows one of the dirty type of cytogenetics called as 17p deletion, such people will be resistant to lot of other forms of treatment, and in them we use this experimental agent called flavopridol. Then one very important thing about CLL is, CLL is the form of leukemia associated with autoimmune hemolytic anemia. One of our topics in the forthcoming days is hemolytic anemias, warm antibody, cold antibody, PNH, paroxysmal cold hemoglobinuria, everything we will wash the linen and go clean to the exam hall. So doctor, if there is an autoimmune hemolytic anemia, then we use rituximab, prednisolone or splenectomy is the option which is available. Ultimately, what is the closing statement we will tell? Curative treatment for the CLL, if we say it is allogenic bone marrow transplantation. Ultimate cure of all miseries is if you are a millionaire, right? If you have money, you are happy. So that is the thing called as allogenic transplantation. It is not an easy decision. Patient should have sufficient money to sustain post-transplant. He need to protect himself from infections because you will do immunosuppression, everything. So that privilege very few people will have, especially in a country like us where everyone is not medically insured. Unlike in some countries other than India, if you don't have job, you will get a pension. If you don't have MD seat, you will get a pension. For everything there is a social security scheme. In India, no, who asked you to not have MD is what you will be asked. So if you get cancer, who gave you permission to get cancer? Since without our permission you got cancer, you please die yourself. So that is the unsecure social status. So doctor, allogenic transplantation. Now that's all the main part of the treatment that you need to know.